presentation this morning is Demographic and Diagnostic Spectrum of Neurosurgical Biopsies, an initial experience from a re-established neurosurgical unit in a tertiary hospital in North Central Nigeria. Today, my co-author and co-presenter is Dr. Kevin Ezike, and the work was done at the Jos University Teaching Hospital in Nigeria in collaboration with other co-authors, namely Dr. Barnabas Mandong, Dr. Ayuba Dauda, Dr. Peter Binitie, Dr. Danan Shillong, and Dr. Akpa Philip. Like I said, we're grateful for this opportunity. Next slide, please. Next slide. So, neurosurgical biopsies are obtained from lesions of the central nervous system. These comprise the brain, the skull, the spine, the spinal cord, and the nerves. The neurosurgical practice is a highly specialized field with wide disparities related to access to care, especially in developing countries where there are few specialists and the poor support for patients with this condition. So the aim of this study was to document the demographic and diagnostic spectrum of the neurosurgical biopsies obtained at the Jos University Teaching Hospital within the first 5 years of the re-establishment of this neurosurgical unit. So, and this is aimed at highlighting the need for neurosurgical services and to include it in health planning and resource allocation. So Jos is a city in North Central region of Nigeria with a population of about 900,000 residents. It is the largest city of Plateau State, a state in Nigeria. It is also the administrative capital. And the Jos University Teaching Hospital was established in 1975 to cater to the tertiary needs of this city and in its environs. Jos University Teaching Hospital actually caters to about 5 other neighboring states surrounding it. So it's actually a large reach of patients that are attended to. This neurosurgery unit was existent early on in the establishment of this hospital, but it became moribund as a result of staff moving out, staff shortages because of movements for better paying foreign jobs. But sometime in the late 2010, one of the neurosurgeons returned to Jos University Teaching Hospital after 25 years abroad. And this led to the impetus to revive this unit. And that was what became the nidus for this work. Next slide, please. So I've just told you about Jos. Next slide. Next slide, please. So the design of this study it was a retrospective, descriptive, hospital-based study of the neurosurgical lesions diagnosed at the Department of Histopathology at the Jos University Teaching Hospital. And this was between January 2010 and December 2015. So we had a total of 151 cases that were diagnosed in this 5-year period, and 145 actually met the criteria. The exclusion criteria were the fact that some cases didn't have adequate clinical history, or the tissue blocks were not retrievable, and so they were excluded. So at the end of the day, we had 145 lesions being analyzed, and that formed the basis for this study. Next slide, please. So this shows the distribution of these lesions, the lesions that were studied in this case. We see that the 0 to 14 age group, the 0 to 14 age group formed the largest group of cases that were seen in this study. The least lesions seen were seen between 60 and 74, the 60 and 74 age group, and the others ranged in between. Next slide, please. Next slide. So we're looking at the diagnostic pattern of the diagnostic spectrum of the lesions seen. The age distribution of these lesions shows a somewhat bimodal peak frequency, with the 0 to 14 age group accounting for 34.5% of cases, and the 30 to 44 age group also accounting for 22.7% of the lesions seen. The 60 to 74 age range accounted for 11.4%, and this was the least number of cases seen. Within the 0 to 14 age range, we had a preponderance of lesions seen in the 0 to 4 age group, and this accounted for 28.9% of cases. The slide we're looking at shows that 31 different lesions were diagnosed, and these were classified into 5 categories as follows: inflammatory and infectious, we had vascular lesions, we had congenital anomalies, neoplastic, and then traumatic and degenerative lesions. The traumatic and degenerative lesions were the highest diagnosis made. This accounted for 37.2%, followed by neoplastic lesions accounting for 33.1% of cases. The congenital anomalies accounted for 21.4%, and these were the most frequently diagnosed lesions, while the inflammatory and infectious group accounted for 6.2% of cases. The vascular lesions were the least diagnosis made. The traumatic discs from vertebral column were the majority of the traumatic disc and traumatic and degenerative vertebral disc lesions. This was generally due to trauma, particularly from road traffic accidents and fall from heights, among other conditions, while the rest was accounted for by degenerative diseases. The inflammatory lesions comprised of a wide spectrum with no particular lesion predominating. However, we had 2 cases each of brain abscess and tuberculosis that were seen in this study. The next slide. The congenital anomalies that were diagnosed overall were neurosurgical neural tube defects. Of these, one slide backward, please. Of these, occipital encephalocele accounted for the most, accounting for 32.3%, and myelomeningocele accounted for 29%. These were the most frequently made diagnoses, while cranial and spinal defects, frontal encephalocele and frontonasal encephalocele, each were the least diagnoses that were made. Next slide, please. These bars show us the behavioral pattern of the neoplastic lesions that were diagnosed within this study. We had 48 neoplastic lesions, all together accounting for 33.1% of all the lesions. These were further categorized as benign and low grade, and then malignant. The benign and low grade lesions accounted for 66.6%, and actually were the most predominantly made diagnoses in this study. The most frequently diagnosed benign and low grade neoplastic lesion was meningioma. This accounted for 43% by itself and 29.1% overall. Astrocytomas, that's astrocytoma grade 1 and 2, were the next most frequently made diagnoses. This accounted for 25% of the benign and low grade lesions, and generally accounted for 16.7% overall. We also saw that astrocytomas grade 3 and 4 were the most common malignant neoplastic lesions, and these accounted for 50% of cases and 16.7% of cases overall of the neoplastic category. Next slide, please. So we're looking at, this just gives us the histological classifications of the neoplastic lesions that were made. So overall, in the neoplastic malignant neoplasms, we had neuroepithelial tumors, being both benign and low grade and malignant, these including astrocytomas, both grades 1 to 4, ependymoma, primitive neuroectodermal tumor, and medulloblastoma. These were the most common neoplastic lesions that were diagnosed in this study. And all together, they accounted for 43.7% of cases. The meningeal tumors were the next in frequency, and these occurred in 14 cases out of the 48 neoplastic cases, and this accounted for 29.2% of all neoplastic cases. The lipomas were the most common type of mesenchymal tumor diagnosed, and this accounted for 14.7% of the cases. In general, grade 1 astrocytomas predominated in young females, while higher grade tumors, that's grade 3 and 4 astrocytomas, were generally more diagnosed in teenagers and in older males. Of the neuroepithelial tumors, 2 cases each of primitive neuroectodermal tumor and medulloblastoma were seen. 3 of these occurred in female children below the age of 4, while 1 medulloblastoma, a 4th, occurred in a male child. The only germ cell tumor seen, a choriocarcinoma, which was metastatic to the brain, was seen to occur in a young female. Next slide. So we're looking at some representative neuroepithelial lesions. We have photomicrographs that were taken from this study. What we see in photomicrograph A is a pilocytic astrocytoma, which we know is a WHO grade 1 tumor. This was diagnosed in a 2-year-old girl with right facial nerve palsy. What we see in the photomicrograph are microcytic spaces surrounded by astrocytes, which are in a fibrillary background with few rosental fibers in the background. Photomicrograph 2 is a representation of glioblastoma, a grade 4 tumor that was diagnosed in a 17-year-old male who presented with visual loss, headache, and visual loss in the left eye, and paraparesis. What we can appreciate is the fibrillary background with extensive necrosis, the atypical astrocytes, which are arranged around blood vessels. Photomicrograph 3 is a primitive neuroectodermal tumor diagnosed in a 4-year-old girl who presented with hemiparesis and visual loss. What we can see in the photomicrograph represented are atypical round blue cells that are disposed in primitive neural tissue, especially at the center. And the 4th micrograph, and last, that is represented is a medulloblastoma grade 3 tumor, a high-grade tumor that was diagnosed in a 3-year-old who presented with ataxia. We can appreciate the tumor cells with scant cytoplasm. Even though we cannot appreciate rosette formation in this section, we had some foci where rosette formation was seen. So this slide just gives us some of the representations of the malignant neoplasms that were included and studied with immunohistochemistry in this study. Next slide, please. What we're looking at here is the age and sex distribution of the lesions. We can see, just like we mentioned before, that the diagnostic group that represented the most age is the 0 to 14 age group where we had the most diagnoses. And generally we have a male to female ratio of 1 to 1.5, just a slight male a slight female preponderance. And the next, the bar that we see on our right shows the distributions. What we can appreciate here is that the brain actually accounted for 75% of the cases, with the spine accounting for a very meager amount, which is typical of the distribution worldwide for brain neurosurgical lesions. Generally, we know that the distribution tends to be with more distributed with the brain and very little lesions. The spinal